Hi everyone, I am Dr. Yasser Osman and I'm going to talk about spinal anesthesia in this lecture. Spinal anesthesia, it has another name called intrathecal or subarachnoid block. Spinal anesthesia is carried out by injecting the local anesthetic agent into the subarachnoid space below the level of the spinal cord to provide anesthesia for operation on the lower half of the body. Anatomical considerations. Vertebral column consists of 33 vertebrae, 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal. The spinal cord extends down to the second lumbar vertebra, L2, and the dural disc to the second sacral vertebra, as we can see with these two red lines. The subarachnoid space between L2 and S2, denoted by the two red lines, contains only CSF and nerve roots, which is the cauda equina. Puncture of the spinal anesthesia can be done only below L2. An important landmark is the highest point of the iliac crest, which is usually the level of L4 spinous process or between L4 and 5, denoted by the red line in the picture. Indication of spinal anesthesia. Spinal anesthesia is indicated for surgery procedure in the lower abdomen, lower extremities, and perineum. Example, appendectomy, inguinal hernia repair, gynecological operation, cystoscopy, anorectal surgery. Contraindications. Absolute contraindications is patient refusal, of course. Patient on anticoagulant or has coagulopathy, because this will lead to hematoma formation at the site of injection, and this hematoma will compress on the spinal cord. Local and systemic sepsis, because this might lead to meningitis. Uncorrected hypovolemia, fixed cardiac output state. Example, severe aortic stenosis. Definitely allergy to local anesthetic drug. Absence of resuscitation equipment. While relative contraindications include neurological diseases in the lower limbs, deformity of vertebral column, cardiac diseases, elevated intra. Preparation for spinal anesthesia. Preoperative assessment, including explanation of the technique to the patient, reassure the patient that adequate sedation will be given, especially if he asked for it. Insert an IV line and give the preload fluids. All vital functions should be monitored before and during the operation. Prepare for general anesthesia at any time during the procedure. What about the equipments? Equipments consist of swabs to apply the betadine, which is the disinfectant material usually used in this procedure, to the skin of the patient. Sterilized gauze to remove the excess antiseptics. Small gauge needle, this one, to give the local anesthetic before spinal puncture. The needle and syringe and the anesthetic drug, and of course the dressing to cover the patient. All this should be put in a sterile tray. Spinal needle, this is the shape of the spinal needle. Look and notice the sharpness of this needle with a stylet inside to occlude the needle space and prevent any debris from the skin or the subcutaneous tissue to enter the needle hole and to occlude it. Patient position. The sitting position, which is the most common position for lumbar puncture. Easier to perform lumbar puncture in this position. Easy to identify the landmark, especially in obese patients. This is the position and how the patient should sit. The other position is the lateral position. It is used when it is difficult for the patient to sit down. If the patient is sedated, sitting position may be hazardous because he may fall down, and this is the lateral position. Note, this is marked area is the area that we inject the local anesthetic. The end of the spinal cord is denoted here, and the end of the sacral sac is denoted as well. Puncture. Position the patient with spine flexed to separate the spinous process and open the spaces for easy passage of the needle to the subarachnoid space. This picture shows how we should put the patient in its right position, not upright but flexed as much as possible. The procedure is performed under aseptic technique. Identify the injection site, the intervertebral space, using the anatomical landmarks, and give the local anesthetic injection in the site we choose to use the spinal needle in. Advance the spinal needle with its stylet in place in a direction perpendicular to the skin but pointed slightly kifalad. A click can be felt as the dura pierces. Remove the stylet. Confirm that the tip of the needle is in the subarachnoid space by noticing the free flow of the CSF. Look at the picture, and this is the CSF coming out of the needle. The local anesthetic agent should be injected when CSF can be aspirated before injection. After injection of the local anesthetic, the needle and the syringe are withdrawn and the patient is turned to the supine position. We have two approaches for performing the spinal anesthesia. First is the midline approach, in which the needle pierces the skin, then the subcutaneous tissue, then the supraspinous ligament, then the interspinous ligament, then this ligament which is called the ligamentum flavum, then the epidural space, then the dura mater and the arachnoid mater. The space between the dura mater and the arachnoid mater is very, very small and minimum, so we can consider both as a one layer. But sometimes we cannot do this. We prefer the paramedian or lateral approach, in which the needle is inserted 1 centimeter lateral to the midline. This is the midline where we insert the midline position or approach, and this is the lateral approach. The needle is directed at an angle which allows the tip to pierce the dura mater in the midline here. The structure that the needle pierces is the same as in the midline, except the ligament, which is the supraspinous ligament and the intraspinous ligament, is substituted with the paravertebral muscle here. This is why, because sometimes in old age the supraspinous and the intraspinous ligament are calcified, so the midline approach will be more difficult to perform. Now we are going to talk about the directions of the spinal needle bevel, i.e., how do we hold the needle? Where does the bevel face? It is better that the bevel is parallel to the fibers of the ligament, like this. This is the bevel, so the bevel should be faced laterally. In this way, it will be parallel to the direction of the ligament, and so it will split the ligament fibers and not cutting it. That is going to lead to a smaller split and less CSF leak, and so less post-spinal epidural headache incidence. Drug for spinal anesthesia. The most commonly used drugs are heavy xylocaine 5% and heavy or hyperbaric bupivacaine 0.5%. Hyperbaric means the density is greater than that of CSF. Xylocaine is used for short operation, 1.5 hours, and bupivacaine for longer procedures. Epinephrine in a concentration of 1 to 1000 in a dose of 0.1 to 0.5 milli can be given with local anesthetic solutions to prolong the spinal anesthesia. Recommended dose for bupivacaine depend on the desired level. For operation on the perineum, 1 to 1.5 milli. For operation on the lower limb, 2 to 2.5. For operation on the lower abdomen, 2.5 to 3 milli may be given, and for operation above the umbilicus, 3 to 4 milli may be given. Factor increasing the level of spinal block. First, the higher the dose, the higher the level. It is not dependent on the volume or the concentration given. Increase intra-abdominal pressure and in case of pregnancy. So we should use smaller dose in these cases. High site and rapid rate of injection. Injection in lateral rather than sitting position. Barbutage, which is the CSF is rapidly drawn in the syringe during injection and re-injecting it again, i.e. mixing the local anesthetic with the CSF. Head down tilt, coughing and straining during or following injection, and the barity of the local anesthetic solution, which is the density of the local anesthetic solution relative to the CSF. There is hyperbaric, the local anesthetic sync with the gravity within the CSF. The isobaric, it remains in the area of injection. And lastly, the hypobaric, which is the local anesthetic rises in the CSF. Physiological effects of spinal anesthesia. Nerve fibers. The thinner fibers are blocked first. Nerve block order is the autonomic sensation is blocked first, then the temperature, then pain, then touch, then deep pressure, and finally somatic motor fibers. This is useful when we test the spinal anesthesia. How? We ask the patient to raise his leg without bending it like this, and if the patient cannot do this, then the motor fibers is blocked, and so we are sure that there is no pain or that the pain fibers are blocked as well. Recovery occurs in the reverse cardiovascular system. Hypotension occurs during spinal anesthesia. The primary cause of hypotension is sympathetic block that leads to venous and arterial vasodilatation, pulling the blood in the lower limb that leads to reduced venous return, reduced cardiac output, and at last hypotension. The amount of hypotension is directly related to the height of sympathetic block. Bradycardia also may occur. Result of lung block of the cardiac accelerator nerves from T1 to T4, so we have unopposed vagal tone. And reduced T venous return may also lead to bradycardia. It is a possible cause for hypotension during spinal anesthesia as well. Respiratory effects. No effect on pulmonary function or gas exchange. Respiratory arrest, which is apnea, caused by high level of spinal anesthesia, is attributed to brainstem ischemia, caused by hypotension rather than any direct effect on spinal anesthesia on the respiratory center. Why? Because even with high thoracic level of spinal anesthesia, the inspiratory muscle function is little affected because the principal muscle of inspiration is the diaphragm, which is innervated by the phrenic nerve from C3 to C5. Gastrointestinal effect. Unopposed vagal activity results in increased secretion, relaxation of the sphincters, and contraction of the bowel, thus providing excellent surgical conditions and better gastric emptying. Hyperperistalsis can cause nausea and vomiting, while renal effect, no significant reduction of the renal blood flow occur, but urinary retention may occur and necessitate catheterization. Reduction of stress response to surgery, because spinal anesthesia block and suppress the release of these stress hormones, example, the catecholamines, the antidiuretic, and also the hyperglycemic response to surgery. Complication of spinal anesthesia. In the operation room, hypotension may occur, bradycardia, nausea and vomiting, failed spinal, total spinal, cardiac arrest, hypothermia, and broken needle or a catheter in the case of epidural. While in the post-operative period, post-dural puncture headache, backache, 6 cranial nerve palsy, urine retention, pruritus, but only when opioids are used with the local anesthetic. Meningitis, chemical or bacterial, and neurological sequelae, spinal and epidural hematoma. Hypotension. Hypotension is the most common complication following spinal anesthesia. More common in old patient, pregnant women, and in high blocks. The main cause is loss of sympathetic tone. So before giving spinal anesthesia, restore the vascular volume in dehydrated patient and give preload, which is administration of half a liter to 1 liter of crystalloid solution before spinal anesthesia to limit the hypotension that may occur. Treatment of post-spinal hypotension is give oxygen mask, intravenous fluids, and vasopressor, especially ephedrine. Other vasopressor could be used like norepinephrine and phenylephrine. Bradycardia. It is more likely with high block and may cause hypotension. If severe, atropine in increments of 0.2 milligram can be given intravenous. Nausea and vomiting. It may indicate major hypotension, so we should really check the blood pressure if nausea and vomiting happens and treat accordingly. Other causes include hyperperistalsis, surgical manipulation of the intestine, and narcotics. The treatment include oxygen, restore blood pressure, atropine 0.4 milligram IV, and antiemetic may be needed. Failed spinal anesthesia. It may be associated with failure to obtain a free flow of CSF before injecting the drug, that is to say, fail to reach the subarachnoid space. The drug may be injected into the subdural space, as we can see in this picture here. The cause may be related to the drug itself, i.e. that the drug is not functioning well. Total spinal anesthesia result from spread of the local anesthetic agent to the cervical spine cord and brain stem, and usually occurs shortly after the block. The signs are profound hypotension, bradycardia, nausea, vomiting, loss of consciousness, and dilated pupil and apnea. Early recognition is the key of management and to ensure complete recovery. The lines of management are intravenous fluids and vasopressor, tracheal intubation and artificial ventilation. Remember that the patient is aware and should be sedated. The effect of block usually resolves at the end of surgery and the patient can be extubated. Cardiac arrest are related to high sympathetic blockage leading to high vagal tone and profound bradycardia and hypotension. Occur mainly in young healthy patients. Prophylactic, preload and aggressive treatment of bradycardia and hypotension with atropine and ephedrine are essential to minimize the risk of arrest. Use epinephrine in refractory cases. Post-dural puncture headache. It is a common complication of spinal anesthesia. It results from a decrease in the CSF pressure secondary to CSF leak via the rent in the dura, which may cause traction in the meninges and the cranial nerves. It usually occurs 24 to 72 hours after dural puncture and may be very severe, lasting for several days if untreated. The incidence is highest in women and least in old patients, and decreases with the use of smaller size needle. It is characteristically intense, often localized to the occipital or frontal regions and the neck, and is worse in the upright position and lessened in the horizontal position. Diplopia or blurred vision may occur. Management of post-puncture dural headache. The prevention is by using smallest possible needle. Insert the needle parallel to the fibers of the dural sac. Maintain adequate hydration and encourage patient to drink fluid 3 liters per day. Treatment usually in 80% of the patient does not require treatment. Keep the patient rest flat in bed, give analgesic and good hydration. If the headache is severe, an epidural patch should be carried out. How can we do epidural patch? By injecting 15 to 20 milliliter of patient own blood into the epidural space of the spinal puncture. This patch will seal the hole in the dura. Neurological sequence, which is also referred as cauda equina syndrome. It is extremely rare complication and may be due to trauma from puncture, spinal or epidural hematoma, abscess formation, and spinal cord ischemia. Early recognition of spinal hematoma, less than 8 hours, and management by decompressing the spinal cord are important to avoid permanent neurological sequelae. Hypothermia. Mild hypothermia can occur especially in elderly, may be associated with high incidence of myocardial ischemia, surgical bleeding, and patient discomfort. Measures to decrease the intraoperative hypothermia include monitoring the core temperature, adjust the OR temperature, use warm blanket, and warm the IV fluids. Thank you.